Hello, everyone. Again, my name is Corisha. I am the physician liaison here at Pediatric Specialists of Virginia. We are so excited to have you all here with us today. Today, we have our amazing Dr. Dulman here, and she is going to be speaking to you all regarding iron deficiency. She has a wealth of knowledge, so we're definitely excited to have her a part of this program with you guys, our afternoon with a specialist. So I am going to have her take it away. I see the rest of you are joining in now, so that's perfect. And here she is.
Okay, so hello everyone. Laura looks like she's somewhere nice outside. I'm stuck here in my office. So any of you who don't know me, I'm Robin Dulman. I am a pediatric hematologist and oncologist. I have been with ANOVA since the end of 2010, so with PSV since its inception back in 2013. I am going to talk to you guys today about some iron deficiency anemia, as well as, if we have time, a little bit about neutropenia, as per your requests. In general, otherwise, I do leukemia and lymphoma, as well as general hematology, and sickle cell anemia are my focuses here at PSV. So I'm going to go through the slides kind of quickly. Feel free to interrupt right in the chat, etc., so that we can make this a more meaningful discussion, so that, you know, if you have specific questions on things, I'm happy to answer them and not just go through slides and give you a talk. Okay, so iron deficiency anemia. It's not liking me. There we go. Starts with, how much iron do we have in our body? In general, we have a good amount of iron in our bodies. Adults have about 3 to 5 grams. Children have less than 3 grams, and it's in different parts of the body, as you can see all over the screen here. That's, you know, it's somewhat sciencey, so I'm just going to kind of skip over some of that. So, you know, when you're pregnant, most of the iron that the mom has is transferred over to the newborn in the 3rd trimester, which means babies who are born prematurely get less iron from mom and are more likely to develop iron deficiency. If you delay the cord clamping, that can also actually help with decrease your risk of iron deficiency as you're older. Children, infants especially, need a lot of iron. They're growing, their weight doubles, their blood volume doubles. And then by a year it triples, as does the blood volume. So they need a lot of iron to do all of these things. Another slide just to kind of see that is talking about your physiologic nadir. When do we expect patients to have a lowish hemoglobin? And it all depends on whether they were born on time or not. So term infants, we usually see that nadir somewhere between 8 and 12 weeks. It can get down to as low as 9.5 to 10. And then the bone marrow kicks back in and they're fine. They don't need extra iron during this period of time, but they need iron in the form of drops or, as they get older, iron-rich foods. Premature infants, they nadir earlier, they nadir lower. While I have here that you can nadir as low as 7, we don't really let most babies get to that point. So these are things to keep in mind, not related to iron deficiency, but related to, was there blood loss in infancy or at childbirth? Was there an ABO incompatibility? Did they need phototherapy? Is there ongoing hemolysis? That can worsen these nadirs, and you can see them sooner. So this is why we have the recommendation for anybody who has an ABO or an RH incompatibility that they get their hemoglobins checked during the first month of life to make sure that their nadir is not going to be lower than you would expect it to be. Typically, infants, we will transfuse them if their hemoglobin is less than 7 to 8, especially if they're symptomatic or not gaining weight. As I put here, the iron stores that babies get from their mothers are typically depleted by about 6 months of life in a full-term baby, which is why you need to introduce iron-rich foods for those children. Otherwise, they develop iron deficiency. If you were born early, you were born small, IUGR, SGA, those patients tend to lose their iron stores sooner, and because they often have less iron stores to begin with. and they can often develop anemia sooner than other babies. Other times when you need a lot of iron is when you're a teenager. You're also growing a lot, your blood volume's expanding, plus girls have the added bonus of losing blood and losing iron, especially with irregular menstrual cycles. So they need a lot of iron as well during this phase of life, phase of therapy. So this is just another slide kind of showing how much iron you need in a day. And then where do we get that iron? Well, we don't get very much of it from breast milk. So you need a lot of breast milk. You don't get really any iron from cow's milk. You need food that has iron in it to absorb that. As we all know, we need to introduce foods with iron in them by about 4 to 6 months of age. Breastfed children should start an iron supplement by about 4 months of age if they're full term, because they should have enough iron stores built up as a full-term baby to not become iron deficient if they don't get any iron supplement in the first few months of life. Formula-fed kids get more iron in their formula, so they don't need iron supplementation. Preterm infants do need supplements starting earlier on, and for the first 12 months. 2 mg per kg per day is like a half an ml. It's not a lot. As we know, food. So, you know, the saying is always that you need iron-rich foods in the form of meats. While meats give a good amount of iron per gram of food, and they are better absorbed, you can still get plenty of iron from vegetables and other ways and other foods as well. Vegetables, grains, lentils, legumes, those type of things. Other ways I try and tell people to get increased iron is to use cast iron skillets or an iron fish. If you don't know what an iron fish is, it's just iron in the shape of a fish. It has nothing to do with a fish. And you can throw that if you make a lot of soups and stews, and it helps give a little bit of extra iron, especially to those kids that are a little pickier eating and don't really eat enough foods that have iron in them, or they're on a, you know, they've become vegetarian, or they've always been vegetarian. This is just the iron cycle. If you like science, you can look at it. The most important part of this slide is to know that this protein called hepcidin, which is in your GI tract, is very important in absorbing iron. And it has now kind of made the old adage of more iron is better to us realizing that more iron is not better, because you can only absorb so much iron in a day. And that in an ideal world with somebody who has really good adherence to their medication regimen, a child that needs iron supplements would be getting them every other day, because then your hepcidin is up at the highest level to absorb the iron, then it goes down after it absorbs the iron, and then it comes back up 24 plus hours later. We all know in the real world that most patients can't remember to take medicines every day, let alone every other day. So I still tend to prescribe iron daily. More than once a day is not helpful, because again, that hepcidin level is already low once you've given the iron once a day. Because then if a patient forgets once in a while, you're still getting iron absorbed, as opposed to trying to have them remember to take it every other day. Then they forget a day, and then all of a sudden they're getting iron once a week, and that's not really all that helpful to somebody who's iron deficient. So hepcidin is important, and it goes down once you absorb iron and does not come back up for 24 more hours. So more than once a day iron dosing is not needed. I tend to use 3 mg per kg per day once a day, and that's really about it. When you get to adolescence, 1, maybe 2 pills a day at the same time. But more than that, again, is not going to improve your iron deficiency any better, and it's just going to make you constipated. We all know that the hemoglobin levels change as you get older. You're born with high hemoglobin, and then it goes down through early childhood, and then kind of starts going back up as you go through adolescence. Males and females tend to be a little bit different, but nothing that's dramatically different, age-based. How do we define anemia? And iron deficiency anemia is just your hemoglobin is more than 2 standard deviations below the mean. And iron deficiency is about 50% of all anemias that we see. And this is just telling us what we already know, that patients who are federally funded programs and low income tend to have higher levels of iron deficiency, partially why it's screened a little bit more. But anybody can develop iron deficiency. It doesn't matter where you live or what you look like. So most important things in aiding your diagnosis is, of course, a good diet history. We all know this, but making sure that whether it's you as the physicians or your MAs or nurses who are screening, asking the families what are their child eating, making sure you know that when you say how much milk are you drinking in a day, many of them will tell you how much they're drinking during the waking hours and don't tell you about what they're drinking in the overnight hours, because you're like, oh, well, you're 2, you should be having milk in the middle of the night. But we all know that there are families that still do that. So how many ounces in 24 hours are they really drinking? We all know that, 12 to 16, maybe 20 ounces is really enough. How often are they breastfeeding? In the first year of life, breastfeed all you want. But as you get older, if you're breastfeeding more and not eating much food, you're not getting that extra iron that you need from food, and you're more likely to develop iron deficiency. It's okay to, of course, continue breastfeeding as long as there's also other food involved. The other thing is, how many gallons of milk do you buy each week? How many people in your household actually drink milk? I am amazed at the amount of milk people buy in the grocery store sometimes. And no, I don't know how many children they have, but most of the time, I'm guessing if you're buying 4 gallons of milk a week, your kids drink more milk than they should. And then, of course, as you get to the young, the teenage girls, a good bleeding history. We've all been burned by, is your period normal? And they say yes. And then you ask more questions and they're like, well, yeah, it happens every 2 weeks and it lasts for a week and a half. And you're like, that's not normal. Might be for you, but not for them. There are bleeding scales that you can download from the internet if there's any concern about a bleeding disorder, whether it be, a kid with really heavy nosebleeds that's leading to anemia, which is not common, or somebody who's bleeding postoperatively or getting a good menstrual history. In iron deficiency anemia, most of these kids' anemia develops slowly over time, so the body really responds, and they tend to have relatively normal vita signs. They often are the kids running around. You'd never know that their hemoglobin was 4, but then you look at them and they're pale. I find some kids, when they're really pale, they look yellow, but they're not actually jaundiced, meaning there isn't any hemolysis going on. They just look kind of yellow. Rarely you get these kids where it developed quickly or their level is so low that they will have symptoms of cardiac dysfunction with a gallop or with peripheral edema. I'll go through the next slide that kind of indicates what else we're looking for. Of course, we need to find out why kids are anemic. Why do they have iron deficiency? In the majority of the toddlers, especially, it's your classic iron deficiency because they're drinking too much milk and they're not eating enough food, or they're eating really crappy food that doesn't have any iron in it. But then you get the slightly older kids. Well, why is a 9-year-old iron deficient? Are they not absorbing? Are they bleeding? Is there something else going on? I've also seen another thing that's not written here is in the adolescents, how much exercise are you getting? Are you a competitive athlete and you're just not eating enough to give your body what it needs for the amount of exercise that you're doing? Just because I'm a hematologist and I can't not show you a slide, here is a slide where the cells are light in color, they're hypochromic, they're smaller than they should be. And then you see extra platelets, because essentially a bone marrow that is trying to make red cells and it can't make red cells because it doesn't have iron will make extra other things. So you can see elevated white count, but more commonly you will often see elevated platelets. Rarely do we see platelets higher than 500 to 700. Once in a blue moon with really severe anemia, you can see somebody with platelets near 1 million. But it's not common. Another symptom of iron deficiency that we're all aware of is pica. So make sure you're asking those questions as well, just to get a good history. And then the big question we often get is, how do I know if this is anemia versus thalassemia trait? If you're just doing a finger stick in the office and their hemoglobin is 10.5, sure, give them some iron, especially if you get a diet history that, is a typical toddler diet history. And you're like, you know what? Yeah, they could have iron deficiency. But if they are religious about taking their iron as prescribed and their hemoglobin doesn't change after a month to 2 months, then it's time to get the full CBC. And you don't actually need the differential because we're not screening for any white cell disorders. We're just screening for anemia. So you can get that MCV, you can get that red cell count, you can get that RDW. And if you're getting a full CBC, please get a reticulocyte count as well, because that's always helpful. Somebody who is severely iron deficient is often will actually have a low retic count because you can't make new red cells without any iron. But it's a good way to monitor their response once you have started the iron replacement. So alpha thal trait tends to have a more mild presentation. Their hemoglobins are minimally low, but tend to be relatively close to normal. MCV is low, but not often as low as somebody with beta thal trait. On a hemoglobin electrophoresis, somebody with alpha thal trait, it's normal. Somebody with beta thal trait, the hemoglobin A2 is positive. Beta thal trait, you can't determine on a newborn screen. Newborn screen will be normal for somebody with beta thalassemia trait. Alpha thalassemia trait can sometimes be detected on newborn screen by the detection of either a variant or hemoglobin Bart's. Hemoglobin Bart's is gamma 4, which is fetal hemoglobin that doesn't have an alpha to match, so it's gamma 4. Well, you stop making gamma because you stop making fetal hemoglobin soon after birth, so that Bart's will go away. But then you'll check a lab and they might have a mild anemia, they might have some microcytosis, and they'll often have an elevated red blood cell count. So that's often the trigger here of the red cell count is often elevated in somebody with thalassemia trait, whereas it's actually often on the lower side for somebody who's got iron deficiency because you just have less red cells. The thalassemia patients will make extra red cells to keep themselves from becoming anemic. We all learned about the Mentzner index when we were residents, and it's basically just the MCV over the RBC count. If it's greater than 13, it's more likely to be iron deficiency. If it's less than 13, it's more likely to be thalassemia trait. If you believe that somebody has thalassemia trait, we usually will see those patients at least once in our office, either as telemed or in person, as a way to just counsel them about it, knowing that they have this trait. It's not going to change. All the iron in the world is not going to change their thalassemia trait. Can you develop iron deficiency and thalassemia trait? Yes. And if you're screening for thalassemia trait in somebody who has definite iron deficiency, don't do your hemoglobin electrophoresis looking for beta thal trait until their iron deficiency is improved, because you can actually get a falsely elevated A2 in somebody who's iron deficient. So other differentials of iron deficiency in addition to thalassemia trait is anemia of chronic disease. And this just kind of goes through, iron deficiency classically has a low MCV, a high RDW, your iron levels are high, your TIBC is high, and your ferritin is low. Thal trait, your MCV is low, but your RDW, your iron levels, and your TIBC tend to be normal, and your ferritin tends to at least be somewhat in the normal range. I don't love that the labs count a ferritin of 15 as normal, because really, ideally, your ferritin should be 30 to 50 to prevent future iron deficiency and iron deficiency anemia. Anemia of chronic disease is that the iron is basically stuck in your macrophages and it just can't get out. So you can give more iron, but it's probably not going to help until you control the inflammation. So those patients tend to have a normocytic anemia. their RDW is frequently normal, their iron levels are low, and their TIBC is low, basically meaning that all of that protein is saturated with iron, but it's not being released into the bone marrow to make red cells. And then your ferritin, because it's also an acute phase reactant, can kind of be anywhere all over the place. So treatment. These slides are mostly thanks to Dr. Yang. So we always like to say iron deficiency anemia is not an emergency, even if you get that hemoglobin back that you tested in the office and their hemoglobin is 3 or 4. If they are completely asymptomatic, which the majority of toddlers are, you don't need to send them to the ER. We welcome phone calls. Try not to call us at 3 in the morning with iron deficiency anemia, but we are available 24 hours a day if you need us. And we're happy to walk you through it. But I would say if there's a kid who classically has the history of I drink too much milk or I eat gummy bears and Pepsi and that's all I eat, and has a hemoglobin of 3 or 4, and they were in your office 3 days before and they looked totally fine and you sent them home, you don't need to send them to the ER so we can repeat their labs. You can start them on iron. You can, if you want, check their ferritin, but you know it's going to be near 0. Start them on that 3 mg per kg per iron. It should be given on a relatively empty stomach. And then repeat their labs with a retic count in about a week or so, and you should start to see a response. Also, lots of dietary education. If these kids have a better diet, meaning they're drinking 0 to minimal milk, they start eating other foods, and they're taking iron, their iron deficiency should be resolved in the next 3 to 4 months. The anemia tends to respond within a month or so. You tend to get to relatively normal hemoglobin because the body is ready, willing, and able to make those cells. There's nothing wrong in the bone marrow. So as we wrote here, it takes about a month to get normal hemoglobin, and then you need to continue the supplement for another 2 to 3 months at a minimum to kind of get that ferritin level to 30 to 50. Once you get that ferritin level to 30 to 50, you've changed their diet, they're eating more foods, they're much less likely to develop iron deficiency and therefore anemia again in the future. I will often transition families after they've done a few months of iron supplements to a multivitamin with iron because it makes them feel better that they're still giving their kid a little bit of extra. But when you're going from 45 to 60 milligrams of iron a day down to 15 milligrams of iron a day, it just kind of gives you that extra for those days when your kid only wants to eat French fries. Different irons that we tend to prescribe, ferritin is the liquid I tend to use because it's more concentrated than like thiazole, which is similar amounts of iron it's like 45 milligrams of iron in 5 mLs. Whereas if you use ferritin, you can get 45 milligrams of elemental iron in 3 mLs. Because it's 15 per 1. It's the infant drops, but they tend to be better tolerated. We all know ferritin, thiazole, they're ferrous sulfate. They have the most GI side effects, and they taste terrible. And all iron, as we know, stains the teeth. So if a family tries ferritin and they can afford, and they hate it, and they can afford it, we tend to switch them to Novaferrum, which you can buy on Amazon or through their own website. It's the same concentrations. For the older kids, Vitron C tends to work pretty well. It's ferrous fumarate. Novaferrum is ferrous polysaccharide. They tend to have a little less GI side effects and are slightly better tolerated. Iron is absorbed better when it's taken with vitamin C, and it's definitely absorbed better when it's not given with dairy products or with other significant iron containing foods, because again, the body can only absorb so much iron at a time. We like to not transfuse iron deficiency unless they're symptomatic. I find the teenagers tend to be more symptomatic than the toddlers, so sometimes we will transfuse them. If a girl comes in with heavy menses and anemia due to their heavy menses, there is an algorithm of labs that we check when they get admitted to the hospital. We give iron, or we start oral iron, we'll give a unit. Usually if their symptoms are resolved, we stop after a unit because the iron will improve their anemia pretty quickly. The blood transfusion should improve their symptoms pretty quickly. And then we will test for bleeding disorders, testing for von Willebrand and coags and those type of things, just to find the smaller percentage of girls that have heavy menstrual bleeding due to a bleeding disorder, as opposed to just abnormal hormones, dysfunctional uterine bleeding. They're having heavy menstrual bleeding that's irregular, we'll often get GYN involved and give hormones in the hospital, and then often send them home on hormones as well. We often get asked, is IV iron better? Most patients respond to oral iron, so we tend to start with oral iron. If you have truly failed oral iron, you have a chronic inflammatory condition that's not allowing you to absorb it, then we will go to IV iron. The main IV iron that we use is iron sucrose, and it tends to need 3 to 5 doses to replete your iron stores. It requires an IV. There's risks of anaphylaxis. There's risk of phlebitis. So if we don't have to, especially in a small kid, we will definitely try and avoid IV iron if we can. As I said before, 1 to 2 weeks to kind of improve your anemia, start improving your anemia and get the retic count up. And then by 4 to 6 weeks, most patients, if they don't have any underlying issues, have resolved their hemoglobin up to a normal level, and then they just need to get their ferritin levels up with another few months. What we got. So these are cases that Dr. Yang put together. We can just very quickly go through them as well. So case 1, 18-month-old, breastfed since birth. Their CBC shows a hemoglobin of 6 and an MCV of 41 with a low retic and a low ferritin. Advice would be either to stop or to decrease breastfeeding, offer food before breastfeeding. Most families will come in when we tell them to decrease or stop the milk or the breastfeeding and give them more food. They kind of are amazed that their quote unquote picky eater now likes to eat everything. Of course, we started iron supplementation. This kid's hemoglobin was up to 10 in a month, and then was normal at 2 months with a ferritin of 10. So we'd continue iron for another 1 or 2 months, get their iron up to normal, and never see them again. These are also kids like this that you as general pediatricians can certainly take care of. We're always happy to offer advice or see somebody that needs to be seen, but not all iron deficiency requires a hematology visit. We do have a lab within in our office, so we can get CBCs back immediately, which some families like, because there's no chasing the numbers as much. Here's another case. These are like actual cases. 3-year-old who's still using the bottle, drinking 40 ounces of milk a day, still drinking at night, was prescribed iron by their PCP. Family thought that he was always described him as a picky eater, so whenever he wouldn't eat, they would give him milk. They didn't really change his diet very much at the beginning, so he wasn't really responding. We saw the kid, we said, stop giving him milk. And sometimes we'll say, stop giving the milk for a period of time. Of course, we will tell them, as I'm sure you guys tell them too, to throw away the bottle, because at 3, they really shouldn't be drinking out of a bottle. And then give the kid food. And eventually these kids get better as well. You know, I'm of the, yes, if you want to give your kid a little bit of milk after the iron deficiency is improved, that's great. But reminding them that it needs to be only 12 to 16 ounces a day. It should only be given after you've kind of eaten your food that has iron in it. We get these cases occasionally. 4-year-old boy presented with iron deficiency anemia. His diet was basically Coke and French fries. I think we all know how to fix that. Tell them to eat more food. We had a kid, I think his diet was Coke and gummy bears. So time to either put in a G-tube or stop giving them those types of food. Better education. So education starts at the beginning, and hopefully these families do realize that eating French fries and Coke is not a good diet. These are the types of kids, they have such limited diet where I would actually say you need to check B12 and folate. because we had a kid years ago who was on the spectrum and literally ate French fries and drank water, and not only he had B12 deficiency, including ataxia, he got a G tube, and then he could eat all the French fries he wanted after we fixed all of his deficiencies. Again, same one. And then, like I talked about, menorrhagia, 12-year-old girl, menarche was 9 months ago. They have irregular cycles. They're bleeding for up to 2 weeks at a time. This is where a good bleeding history helps. Are you spotting for every day for 2 weeks? Are you changing a pad every 1 to 2 hours? Are there large clots? Are you leaking at night? Those are all the questions that we ask to kind of discern how heavy the periods are. And it may say that you think that they might have a bleeding disorder that's leading to their heavy menses. We can definitely pick up patients who have von Willebrand or other bleeding disorders that was not picked up prior. Not every kid with von Willebrand has heavy epistaxis. If you haven't had major dental work, you haven't had a tonsillectomy, you really haven't been challenged until you have your menses. So we will pursue bleeding workups in many of our patients who have menorrhagia, especially menorrhagia that leads to anemia. So this kid had a hemoglobin of 7, an MCV of 65, and a ferritin of 5. If this kid was seen in the ER, most likely they were seen in the ER because they were symptomatic, they were dizzy, they were weak. They often would get admitted and get a transfusion. For those symptoms, we would still start iron supplementation and then do the bleeding workup. Occasionally we'll do this whole bleeding workup and nothing will come of it. And that's when we as the hematologist will decide if we need to look for other bleeding disorders. Is there something wrong with their platelets? And then the treatment for dysfunctional uterine bleeding that is just due to abnormal hormones or that is due to a bleeding disorder is still birth control pills. So unless there is a reason why the patient can't go on birth control pills, it's still the best way to control menses, and it works for the majority of patients. The low estrogen ones tend to not help so much when it's due to dysfunctional, the HPA axis. You need the higher estrogen ones to get better control. As I talked about, nosebleeds. This is pretty severe. It's pretty severe for somebody who has a history of nosebleeds to bleed down to a hemoglobin of 4.7 with an MCV of 59 and a ferritin of less than 1. So clearly this kid has had other reasons why he has iron deficiency, but bleeding 4 to 5 times a day is not normal. So that kid should see a hematologist and get a bleeding workup. And this kid had an extensive workup to try and figure out what is wrong. The ENT said broken veins, which to me means that he might have hereditary HHT that I'm blanking on what it stands for at the moment. Other things to consider when somebody has nosebleeds are collagen disorders. Those patients also can have excessive bleeding from their nose. Rarely does that lead to severe iron deficiency anemia unless there's also a poor diet and poor iron sources in the diet. And then another big one we get is chronic blood loss. Sometimes we're the ones that actually diagnose the IBD. Sometimes it's the GI doc sending us the patients who have already been diagnosed with IBD and saying that they're iron deficient and they need iron. So we had a 12-year-old boy who had syncope. He was evaluated for all the causes of syncope, and then he was referred to us because somebody noted that he was anemic. And then with further questioning, you get a history of abdominal pain, you get a history of soft stools, frequent stools, not uncommon in a 12-year-old for the child not to tell his parents that his poops looked funny. So it wasn't really caught. Often these kids, you'll often notice that they're not growing well. Same thing with the celiac patients. You'll have a slow growth, lack of weight gain, or other clues that might make you think that the iron deficiency is due to an underlying GI cause, not absorbing the iron well, or loss through bloody stools. So we'll often do a screen. Sometimes we'll send a stool calprotectin. I'll often do a screen with ESR and CRP. I will sometimes screen patients looking for celiac if I find anemia that I can't really find a reason for. And this kid was diagnosed with IBD. Hopefully, once he got his IBD under control, then we can get his anemia under better control as well. The GI docs will often send us a patient for IV iron because they claim that the patient can't tolerate oral iron or they can't absorb iron. The issue is somebody who has uncontrolled IBD, who is still bleeding or still has evidence of inflammation with high CRPs, abnormal calprotectins. Those patients mostly won't tolerate iron or won't absorb the iron enough to improve their anemia. Once they have better control of their IBD with medications to control the IBD, many of those patients will respond to oral iron and don't necessarily need the IV iron. However, patients who have uncontrolled disease, they end up needing IV iron, and we kind of have to continue the IV iron until they have their IBD under control. And for some patients, it's easy to get their IBD under control, and other patients, it's a long, drawn-out process of multiple medications. Kind of still there. So this is just a slide that basically shows that if you have ongoing inflammation, you're not going to absorb iron very well. But if you don't have evidence of ongoing inflammation, your ability to absorb oral iron is not all that different than a patient who doesn't have IBD. And then that's just another one. So kind of, as I said, you as the primary care providers for these children, especially in the toddlers, it's really easy to diagnose. It's really easy to treat. The big thing is you can't say, here, try some iron and come back in 3 months, because the majority of the patients will take the iron until it runs out, which is usually maybe a month, and then stop the iron. And then you see them 3 months later and their anemia hasn't changed. Because they didn't complete their course of iron, or they didn't change their diet adequately enough, or there's something else going on. So these kids, when we see them, we tend to see them once or twice in the first month. Then if they're having a good response, we'll see them monthly or every other month until we send them back to you guys for follow-up. So that is my iron deficiency talk. Does anybody have any questions?
Dr. Dulman, I have a question. Thank you. That presentation was great. I saw on your slide where you mentioned the cutoffs. I think you mentioned 11. So we usually do the hemoglobin at age 1 and age 2. Mm-hmm. Have what specific value? I've tried to find this in Harry Elaine. I can't get an exact number of what we should use for age 1 and what we should use for age 2 for the value for
right. I kind of say anybody above 10.5 is probably fine, but needs some good diet education. Especially if they're a kid who's transitioning off of formula, where they were getting, all that extra iron in formula, to making sure that the families really understand milk is not formula, milk is not formula, milk is not formula. And that you really need food to continue that iron, and that they need not a lot of milk in their diet. They need a lot of food in their diet. And then, less than 10 is something where, yeah, I would definitely treat somebody who's less than 10. Because they really should be at least 11, 12 by 2, I would say.
So I'm sorry, so 10.5 at age 1 will be the cutoff, and then
maybe 11, like 11.5, I would be a little more cautious when they're a little bit older. But okay. I kind of say anybody less than 10.5 probably has a little bit of going on. Do you guys have just the finger stick in the office, or do you have a CBC machine?
We used to have a CBC machine. We no longer have that, so they all get sent out.
They all get sent out. So then you have all the information too. So it's like, are they 10.5 with an MCV of 70, or are they 10.5 with a normal MCV? Because obviously it's a range. Not everybody is going to be 12. Not everybody at 10.5 is actually anemic. So if you get more of that information, it kind of helps you You know, yes, the lower limit of normal for MCV is mid-70s, but anybody who's at 70 or lower, unless you know they have a thal trait or believe they have a thal trait, they've got some iron deficiency at a minimum. But those are the kids, if it's just a mild iron deficiency, a few months of iron is probably going to make them, or even a multivitamin is probably enough, as long as they're not turning into milk junkies.
All right,
So
great.
maybe instead of getting the finger stick hemoglobin, we should be getting the finger stick CBC since we have to send it out
Yeah.
to avoid having to bring them
Well,
back.
and you don't, as I said, unless there's concern about infection, you don't need a differential, because then I get the referrals for, well, now they're neutropenic. But if you didn't check the differential, you wouldn't have known they were neutropenic because they're clinically well. So yeah,
I think
if you
that's-
can get like the top half of a CBC, that would always be more helpful. Because it just gives you that extra information.
I was also wondering, I've heard that if you're concerned about bleeding disorder, that we should just go ahead and send them to you anyway, instead of doing like a whole, I mean, other than the basic stuff, rather than doing like hemoglobinopathies and that sort of thing, because the like von Willebrand's in particular, I guess the von Willebrand's factor is not really a definitive thing. And so like they could still have it, or the type or
Right,
whatever.
so
And
it's like with von Willebrand, if somebody's got a bleeding disorder, if you have access to a NOVA, I'd probably look up the algorithm that's on there. That for the like teenagers that we admit in the labs that we send, because I find often what happens is that half the tests are sent, but not all of them, or the wrong tests are sent, or so that if you have the guideline to follow you and you order the first set of tests, that's great, because usually we don't diagnose von Willebrand unless we have 2 sets of values that are abnormal. And von Willebrand is also an acute phase reactant, so that when if they're really stressed, they're having really heavy menses, they're having symptomatic anemia, they often can have high levels that then will come down to below normal potentially, if they truly have disease. You know, so if somebody has normal levels but not high levels when they're stressed, they could be normal. They could be below normal when they're not stressed. So we always
okay. So I
the-
see you can kind of get falsely reassured by a normal von Willebrand's. Okay, yeah, no, that's helpful, I
and
think.
it's like if it's just heavy menses, the treatment is still usually birth control pills. But if you're worried that they truly have von Willebrand and then they're gonna have, you know, a biopsy of something, well, then we really need to know what their disease is. So we can give the right advice, you know, pre-procedure or pre-surgery or that kind of thing. Like I had a kid that I got consulted on in the hospital who kind of had these wishy-washy von Willebrand levels done previously, and there was one that was low enough to say, oh, this kid might actually have a bleeding disorder, but there was no time for me to repeat it again. They were about to have a procedure, so I had to treat them. And I had to treat them with factor, not recombinant factor, with plasma-derived factor for their procedure. So if we can, you know, complete these workups before they need anything emergently, it's always helpful as well. I am not going to get through 46 slides in 10 minutes, but I don't need to. But we kind of led into that neutropenia talk a little bit. There's a bunch of cases in here, but I'm going to kind of skip over. This is something that you never look at. This is how our cells are made. So neutrophils, you know, they're made in the bone marrow. They come out to circulation. They live in the tissues. They don't live very long. They live less than 12 hours. And neutrophils can last in your tissues 1 to 2 days. A lot of your neutrophils are marginated, so they're on the edges of your blood vessels, and then when you're stressed or need them, they're available as needed. Neutrophils also, the neutrophil count also varies by age, but typically, if it's less than 1,000, it's going to be abnormal. But you can see that the ANC can be lower in younger kids. So when do we worry about neutropenia? We worry about neutropenia when it's causing symptoms. So the majority of the patients that you guys are going to see are the kids where you're getting a CBC because they were ill, or you're getting a CBC because you're screening for their anemia. and you find a differential that all of a sudden their ANC is 200 or 300. These are typically otherwise normal, healthy kids who don't have chronic oral ulcerations, don't have gingival inflammation, don't have recurrent skin infections, don't have recurrent, otitis media, don't have recurrent pneumonias. Those are the ones that we worry about, whether they're 15 or 15 months. I'll get these kids, well, your ANC is 800, but they've never really had any problems. Those are the kids that probably just demarginate more and they live at the lower limit of normal, but when they need their white cells, they work. Same thing with like the autoimmune or benign neutropenia of childhood. Those kids are usually found incidentally, and they don't really give a history that would make you concerned, because those kids, their bone marrow still works, even if it is antibody mediated, and the antibody, just like an ITP, is destroying their white cells when they get out to the periphery. When they need white cells because they have an ear infection or they have an illness or a strep throat or whatever, their bodies are able to make more white cells and overpower that antibody and not get significantly ill. Yes, we have the occasional kid with what we would otherwise call benign neutropenia that ends up with a peritonsillar abscess or something along those lines. But there are kids with normal immune systems that develop those things too. So who knows if the neutropenia really contributed or not. So kind of, as I said, these are the basics of what we ask about. Is there any family history? Are you worried about a severe congenital neutropenia? Patients with severe congenital neutropenia or cyclic neutropenia usually tend to present within the first few years of life, because they're having these recurrent infections, so that they then have had labs done, or they've had to feel the need that they need a further investigations. Those are the kids that end up needing GCSF. The kids who have benign or autoimmune neutropenia of childhood, it tends to resolve. It tends not to be associated with major issues. Often when we see them in the office, we're there to just get a really good history and reassure the families that there's not much going on. It used to be that the benign neutropenia patients, we would still see them when they were ill and draw labs. Now that the evidence really shows that most of those kids don't develop major issues, their risk of bacteremia is really low, that I tend to go with, if your kid looks fine and they have a fever, treat their illness and their fever. But if they look ill, or they have recurrent symptoms or a prolonged symptoms illness that isn't improving, then yes, get checked out. So I think I'm going to skip all of these because you guys know these things and we have 10 minutes. This is what we kind of know when to CBC. So you have a kid with neutropenia. If you are concerned about cyclic neutropenia, they give a history of recurrent mouth sores. They give a history of like every 6 weeks or every 4 weeks, he tends to get an ear infection or he gets these mouth sores. That's when we worry about cyclic neutropenia, and we will get twice weekly CBCs for about 6 weeks or so, to kind of see if there's any pattern. If there's no pattern, then that's not the diagnosis. If there is a pattern, then we will often go and do the genetic analysis looking for congenital neutropenia or cyclic neutropenia, which are these DNA tests that are here. If there are other concerns with the neutropenia, obviously, if we think there's leukemia, we think there's something else, we'll do those other tests. Anti-neutrophil antibodies, we can send. They're not a great test. If they're positive, and they kind of give us the diagnosis of autoimmune neutropenia, but not all kids with autoimmune or benign neutropenia actually have antibodies, because if it's negative, it doesn't actually rule out the disease. So usually I just treat these patients clinically, but if we really are worried that there's something else going on, we will send the antibodies. Some of these other tests that are on here are more when you're looking for congenital disorders that are associated with neutropenia, and when to worry. So why do we worry about neutropenia? Obviously, patients who are neutropenic are more at risk of developing infections. There's a difference between how I make patients neutropenic and how otherwise patients with neutropenia present. I give kids chemotherapy, so not only am I altering their ANC count, I am also altering their mucosal barriers. I am altering how their T cells work. I am altering their immunoglobulin levels. So those kids are at much significant risk of infection, and they develop significant infections when they're neutropenic because they lack a whole immune system. In a kid who just has severe congenital neutropenia or has cyclic neutropenia, they can develop infections, and sometimes they can be severe, but other kids can actually be fine. There's definitely not an exact genotype phenotype correction. If you have immunodeficiencies or immunoglobulin deficiencies in addition, you're more likely to develop issues. Your risk for having severe infections is near no different than anybody if your ANC is greater than 1,000. Less than 1,000, between 500 and 1,000, it's a little bit higher, but rarely do we see significant things unless their ANC is less than 500. Gonna go through that. You know, in a kid with an ANC less than 500 due to severe congenital neutropenia, due to aplastic anemia, due to chemotherapy, yeah, those kids automatically get admitted. If you have an ANC less than 500 with benign neutropenia, we don't automatically, not only do we not even admit you, we often don't even evaluate you. If you really truly look like you just have a viral infection and a fever. So kids who have inherited neutropenias, these kids need their immunizations. We prefer not to stick things up people's bottoms unless we have to. We try to avoid catheterizing patients. Dental hygiene is always important for everybody, but they can go around to school and daycare and those types of things. There is a thing called the neutropenic diet, has basically been disproven. It doesn't decrease your risk of infections. The acid in your stomach is pretty good at that. So the only patients that need to follow severe diets like this are patients who are post-transplant primarily. These are good, but I don't really feel like going through them. Just back to basic definitions, a normal ANC. If you are less than a year old, the lower limit of normal is 1,000. Everybody else, it's 1,500. We know that there are some patients out there, especially those of African or Middle Eastern ancestry, where their baseline ANC is less than 1,000. We know that this is due to really your genetics and not necessarily due to where you come from, due to the Duffy antigen group on your red cells. These patients they're not patients. They don't develop increased risk of infections. They're at their baseline, although the definition of mild neutropenia is an ANC of 1,000 to 1,500. Typically, we only see major issues in patients who have severe neutropenia. I'm not going to go through this stuff. So this is the most common neutropenia we see. It's acquired neutropenia. It's acquired because I did it to them, because I gave them chemo. It's acquired because they have viruses. And that's really the most common cause of acquired neutropenia. You got a kid, he's had a bad fever for 5 days, you get a CBC, their ANC is 400. What do? If they clinically look well, there's no signs of bacterial infection, then you can just treat whatever infection you think they have and not worry about their ANC, and then wait for them to recover and repeat it. Yes, there's newborns that develop neutropenia. They can be from fevers, infections. Many newborns, you're not going to do anything different. You have a newborn or a young baby has a low ANC, your anticipatory guidance is basically going to be the same. There are drugs that can do it, antibiotics. You can get the beta-lactams that can do it. Bactrim can do it, anticonvulsants, especially Depakote, other drugs as well. That there are many drugs out there. If you read like all the adverse effects, many of them have a side effect of neutropenia. So if it's a drug that you can withdraw, then and replace with something that has less of a risk of causing low neutrophil counts, go for it. And then, as I said, there's neonatal alloimmune as well as autoimmune neutropenia of childhood, like we talked about. Both of these tend to be passive, they tend to be temporary. In the infant, it usually goes away because it's just mom's antibodies attacking baby. So those are usually gone by 2 to 3 months. In autoimmune neutropenia of childhood, it can last a few years. but typically those kids are totally fine. Many of them, there's probably way more kids out there that have benign neutropenia that you don't know about it because they're clinically well and you're not checking CBCs. Again, for any of this, if you have any questions, feel free to call us. We are available in the office every day, as well as at night and weekends for emergencies as needed. Kind of skipping through all of this. We kind of talked about this. So if you were to do a bone marrow in somebody who has acquired neutropenia, it's normal. But we don't do bone marrows unless there's a concern that there's something else on. The treatment primarily is observation. And as I said, it usually resolves within about 2 years or so. Rarely can it be associated with other autoimmune diseases, but typically autoimmune neutropenia of childhood is associated with, young children, when you rarely see these other autoimmune diseases. So as I said, the etiology of transient neutropenia in children with febrile illnesses is viruses, viruses, and viruses, and then rarely caused by all of these other topics. Premature infants we talked about, and then the inherited neutropenias. These are the kids that have bone marrow failure syndrome in one way, shape, or form, and usually have something else that makes you think that they have these disorders. We can test for them. There's lots of genetic testing now, so if there is a clinical reason to be concerned, we often send them to genetics and do the testing. I kind of talked about severe congenital neutropenia. It's pretty rare. Most of these kids eventually get a bone marrow transplant, and they have a risk of developing leukemia. And then there's the other diseases that you'll see on a board exam. So I'm going to exit there. So I know that was a really quick overview of neutropenia, but by the conclusion is that the majority of kids with neutropenia, it's either benign neutropenia or viral induced neutropenia, tends not to be associated with significant illness, and most tend to resolve on their own.
Awesome.
Okay.
Well, thank you guys so much. You guys have a great day, and we'll see you at our next talk. Thanks, Dr. Dulman. Thank you so much. That was so awesome.
Thank you,
Thank you
Dr.
very
Horn.
much.
Thank you.
Thank
All right,
you.
thanks everyone. Bye.
Bye-bye.